Well, I think it's a great question, and a question that we get asked often at Simon Med with our focus on women's health and cardiac health. I think the really important point to note is that 1 in 3 women will be affected by some sort of heart disease. And so, what does that mean? Well, I think, what often from a clinical lens, what happens is we get a lot of inputs from labs and we get blood pressure, and we try to use these findings to give a complete picture of patients' heart health. But we know that there are other factors involved, right? Family history, history of gestational diabetes, smoking, uh, sleep quality, of course, the labs. And many of these manifestations, we want to be able to see visually issues. And that's why at Simon Med Imaging, for example, we offer a mammogram plus heart exam, which actually can go beyond and do these extra layers of heart health analysis. There are many factors that should be discussed, and family history is certainly a major component, but even certain contraceptives can influence cardiovascular risk, especially those that contain estrogen. The blood pressure and specifically uncontrolled hypertension or smoking history can also contribute quite a bit to having a thromboembolic event or like a stroke. And I think our colleagues in OB-GYN do a great job taking an assessment of all these. And usually when we get them from an imaging center standpoint. Patients come to visit us for a mammogram or a cardiovascular assessment. We're very fortunate because we get a lot of these risk factors in the physician notes, and therefore we can then best advise patients on what the best test is when they come to see us. And I think the big picture here is that women's cardiovascular health isn't a one type or one input assessment. Whether you look at pregnancy, contraception choices, menopause, age, um, estrogen, supplementation, all of these are factors that influence cardiovascular health. I would also say hypertension, whether in pregnancy, so gestational versus baseline uncontrolled hypertension, gestational diabetes, preterm delivery. These are all factors that are associated with increased lifetime cardiovascular risk. And so just going through and identifying these factors, taking into account the labs and any cardiac preventative scans, all are very, very important in deriving a cardiovascular risk score. From an imaging standpoint, I bring it back to what we can do at Simon Med. We can provide uh, imaging-based risk, whether through a calcium score, a CCTA, through a nuclear scan, or even from a mammogram. And I think that's what's very, very differentiating. From an annual mammogram, we can assess the presence of breast arterial calcifications. And we know when a patient has breast arterial calcifications, there is some sort of correlation with cardiovascular disease. I think that's what's very important. Coming in for preventative health scans and screening. There are a number of different tests available, right, to assess cardiac health. And I think it's important that we take a zoom out view of this, right? Because you can get into the really high-end exams, but what we're noticing from our lens is that heart disease is so profound, right? 1 in 3 women will be affected. And yet, the amount of screening that is done for heart health is so fractionally small. It's so minimal. And that's why, you know, what we try to do, again, at Simon Met here is we try to take the zoomed out view. We want as many patients that come to see us for any sort of exam, whether you're coming in downstream to evaluate for endometriosis, right? One of the big problems that affect women that's just massively underdiagnosed. Or you're coming in for a DEXA scan to assess your bone health, or you're coming in for a mammogram. We do our best to bring in heart health with every single sort of exam possible, right? So we look for opportunities to educate women about their heart health, even when you're coming in for a mammogram, for example. We'll give a personalized report, show where there's maybe breast arterial calcifications, and then give patients personalized information on next steps on what to do. So I know it's simple to talk about, well, what's the most precise test I should be looking for? The more important piece here is the zoomed out view. How can we get our patients screened? Because this is a national, international problem, and opening up that funnel to have the most patients screened is critical to the bottom line here. You're going to your OB-GYN to talk about, fertility, or you're going to your OB-GYN to talk about, the pregnancy you're about to have, you're having post-pregnancy. This should be part of the routine conversation before symptoms, before complications, before disease becomes irreversible. The OB-GYNs are in a really fortunate position to be able to capture the attention of the patient, oftentimes before the heart disease becomes a significant problem that is not reversible.